So we are going to do a 2-level canal stenosis release, and the patient has claudication. The distance is around 200 meters. So here we are going to do a midline biportal endoscopy. So we do not do unilateral, we do midline. So we start with the namaste point. That's the highest point for the surgery. Take a shoot. So that's the namaste point. You show it there, namaste. The namaste is the area where you have the highest point for the, this is the namaste point for L4-5, and another shoot. This is the namaste point for L3-4. So we, after identification of namaste point, now show it here. You take 3 lines, one is a midline, one is a left midline, other one is a right midline, and you on the left midline you start the surgery. So we take an incision. There is no triangulation involved in the surgery. This is a triangulation free UBE surgery, midline biportal shoot. So you see I am exactly at the namaste point, and we continue dilatation, show it here. And these dilators are specially designed for the UBE's midline biportal endoscopy, and the incisions are very, very small in midline biportal in comparison to the unilateral biportal endoscopy. You will see there is no triangulation, so no time taken for the process of triangulation. Surgery is very, very fast. We will do 2 levels in a very short time. Probably we tell the patient we are going to do the surgery in 15 to 20 minutes, and that is the ideal time for every surgery. Shoot. So it looks like a minor surgery on the patient, though it is done under general anesthesia, but the surgery is very, very fast. Surgery incisions are very small, much better than the monoportal endoscopic technique because of the smaller incision. I can call it as a hybrid technique between monoportal and biportal, because the docking point is according to monoportal and the solution is according to biportal. Who is the there's so saline?
Open.
So this is a 0-degree scope where we are starting. Saline, please. So front throwing camera. Saline. Stop. So you see how fast we can reach to the spinal lamina junction here. Ablate. So you see we have reached to the spinal lamina junction in very short duration time. And this is the, you see the interspinous ligament which is preserved in surgery. I take only 2 seconds to reach the spinal lamina junction. We call it ultra fast surgery. So we reach to the base of the spinous process. We demonstrate the C here. The C is being demonstrated. Coagulation. Coagulation. Saline. So, stop. Coagulation. So we don't interfere with any muscle integrity. We directly land in zone space and continue our work. Drill, please stop. So see, we reach to the interspinous area and we are going to drill it because it's a canal stenosis. We will drill the base of the spinous process. This is L4-5 level. 3-4 is also we are going to do. The foramens are wide open. We don't need a foraminotomy in this case. I'll just drill the base of the spinous process. Drill the base of the spinous process. I'll show you the contralateral zone space from here. Stop. Drill, please. As I always tell you, this is a mind drilling technique, a faster drilling technique. Some of the people say it is a very unsafe technique, but you see nothing happens if you actually understand the technique. This technique is done with very soft hands. You only move the drill horizontally. That makes the surgery definitely faster and precise. So you don't wait for the bone dust to clear when you are going for this drilling technique. So you see the flavum is visible now. The flavum and the middle cleft is visible now, the midline cleft, you see. Carry please. No much saline. Don't give saline. Don't give saline. Okay. So you see this is the ipsilateral side and that's the contralateral side, and we are at the center of the surgery. So both the butterfly, you see the head of the butterfly is here at the center, and you give me Carrison 40 please. Okay, the epidural space is visible now. Ablator please, drill please. Ablate. Ablate. Stop. Ablate. Stop. Drill though. So once we do the work on the cranial level, we go to the caudal lamina to drill the caudal lamina, and the caudal work is also done. So you see caudal drilling also we do by the diamond drilling. Okay. So we reach to the inferior lamina. Carrison please. So now the thecal sac is visible, you see. Okay, this canal looks stenosed, and we lift it and cut it, the flavum on this side and on both the sides. The power of endoscopy 4th generation, I believe, is the saline and the bimanual surgery, which makes it is more easy to operate both for the surgeon and for the patient. Saline please, coagulation please, coagulation. Coagulation. Okay, so you see the thecal sac is getting decompressed. Coagulation. So Carrison please. So now this is the technique how you should handle the saline, please. You lift it and cut it. Lift it and cut it. You lift it and cut it. This is the way you should do the technique. This is saline. Okay, so this is the blind spot work you are going to do. This is the contralateral facet, and this calcium, please. Curved calcium, please. Very carefully you should go there. I lift the like this and then we remove it. Is the trick we follow. Saline. Okay. The cord is getting definitely decompressed. It was very compressed. So my job is to do a good posterior decompression and little foraminal work from inside the canal, and that is the trick to a good surgery. Whistle, please. So you see the exiting root and the disc on contralateral side is the facet on contralateral side. This is the superior articular process. Can you see? This is the superior articular process. Okay. So we trim the medial border of the superior articular process. And now see, I have not touched the inferior articular process at all in this surgery. I have just gone under the cave. So we worked from inside the canal and do this surgery. Saline. Carison, please. So this part of the flavum has to be released, and this is a part of foraminotomy. Okay. The traversing nerve root work is over. So axilla is visible. Now you can see the pedicle on this side also. Okay. Well decompressed canal. We don't need to do anything extra here. Yes. Very good. So that side decompression done. Only this side lateral recess clearing is needed. The lateral recess has to be cleared well. Some millimeter extra of the lateral recess Has to be clear. Oh, yes. Okay, this side axilla is also seen. Traversing with axilla. You should always see the axilla. It is very important part of the surgery. So, the axilla, if you do not see, means there is some telescoping. So, you see the axilla on this side, you see the axilla on contralateral, contralateral side. See the hook, please. You see the axilla on this side, looks good. The disc also looks good. I just need to shrink it. We don't need to decompress it, only the free, only soft disc is there. So, as the annulus is intact, we'll do annuloplasty coagulation. Annuloplasty, disc preservation surgery, you can call. We preserve the disc, which is not possible in microscopy. You cannot shrink. Stop. Definitely in endoscopy, all the ways of endoscopy, you can shrink the coagulation. Stop. Coagulation. Stop. Okay. Hook, please. Carrison, please. Bigger hook, carrison. So we take a bigger hook just to see the foramen, and we'll call it a day for the patient. Yes, we also have to do a decompression of upper level. So this level decompression took us only 17 minutes. We don't need to see exiting here because it doesn't look that compressed, because the flow and everything looks better here. The hook, please. Bigger hook. We'll see how the exiting route is. It is good. Looks good. Saline. Coagulation. Coagulation. Stop. Coagulation. Stop. Coagulation. Stop. Carrison, please. Okay. Looks fine. No need to decompress the disc. Okay. This side also looks free. Hook, please. This side also the root looks free. This side also the root looks free. Pain was more on the right side. Curate, please. Little exiting root work will do. Carrison, please. Okay, so this level is over. Now it is 20 minutes. Now I will go to the other level, which is from same incision. You see the size of incision, very small. We convert this into the working portal now and focus on the namaste point. Take a shoot. Another point above, both equal distance from the namaste point. This is complete surgery is based on namaste point. You shoot. Okay, so now we will see the portal shoot. Okay, so this is a namaste point for that level. Scopy portal is made here. Same on the portals. This portal. So one, you see the size of incision, very small. Shoot. Okay. Take out my specs, please. Okay. So portals and entry points is made in similar way for the previous surgery. With this same surgery is made. Now we are done. Now again we start with the saline flow. You see how fast I reach the spine lamina junction. Saline, please. Coagulation. Ablate. See, we have reached to the spine lamina junction. Okay, the C point, so fast, doesn't even take seconds. But if you do triangulation, it will take a lot of time. You see the preserved interspinous ligament above. So you just work below the interspinous ligament. That's the key. Stop. Drill, please. So your surgery ideal should take 15 to 20 minutes max. I said 20 minutes. Previous surgery was 20 minutes. That is fast. We do. We say and do. Then we start with the drilling process with the diamond drill. So we are drilling the base of the spines, but the same. Every surgery looks the same. Same standard steps, but exiting work if needed. So we drill the base so that the scope goes inside. Okay. Now give me Carrison. It's so seamless technique. Very easily can be done as if we are doing an open surgery. The speed is same as even faster that open surgery, no bleeding. Definitely a good technique for our elderly population who suffer from severe canal stenosis and for all spine related issues. Drill. So we drill the base of the spinous process. Contralateral lamina drilling, ipsilateral lamina drilling. Then once you are done with the butterfly part, the central cleft, then we go to the Carrison, please. Drill. Okay, so you see the both the central cleft and the flavum released from both the sides, from this side, that side. Now ablator please, once it is released we decompress the ablet. The above setting of the RF, sometimes people ask, is 7 initially, but once we open up the flavum, I do not use the plasma or the ablator below, I only use coagulation drill. So now I have reached to the inferior part of the and this is a quite safe technique in the tactile dealing. Yeah. Chisel please. Once you drill, then you chisel. So, chisel. Okay, tradition please. Saline please. Correction curved. Okay, thecal sac is now visible. You just have to decompress this level. The next case is 2 levels, right? 3? Okay. No, I saw both the levels. I think we need. Okay. We'll also record the other case. Yes. Okay. Chisel, please. Stop saline, please. No saline. So you see the decompression. This decompression was done only in 11 minutes. Chisel. 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 So this is the way we should do midline. It is a faster technique. So I wish all should adopt this Carrison, please. All should adopt this newer revisiting UBE technique, where you can do the surgery a little faster, and so that you can attempt multi-level surgeries easily. Because the criticism we face for UBE is people say it is a longer duration surgery, but with this technique you can do the surgery very, very fast. Coagulation, please. Coagulation. Stop. Carry some. Saline. Curved Carrison. Bigger curved Carrison, please. So only this side. No, this I need this one. Not working. Normal. No water, please. No. Okay. So this level is almost done. Normal Carrison, please. Okay, so decompression over. Coagulation, please. So we'll find out the oozer and coagulate it. So this is the area where we're getting the epidural ooze. Coagulation. Coagulation. Look, it looks like there is a disc, but we won't remove it, we'll just shrink it. It is a hardened disc. Huh? So all discs need not to be removed. This faucet, please. Root retractor, please. Then they give me the RF. Hold. So we'll do a little coagulation and close it. Decompression is over. Coagulation. This is a calcified region, you see. Calcified. The RF is enough to stabilize it. Okay. Coagulation. Okay. Stop. Okay, so the decompression of this level and decompression of this other level is finished. Saline, please. So you see decompression of this level. After end of the procedure, you should inspect both the levels for any hematoma formation so that you can remove all the bleeders. Thank you so much. Thanks for the patient listening. Okay.